Well, I didn't know there was a top 10 list. It must be Letterman's list, though. But thank you for whoever put me on that list. You know, in my office, we have a saying when I see patients, it's got to be something. You know, you come to see me, you've been everywhere. I'm completely sure you're telling the truth, and I'm sure it's something. So we kind of start with that. And to be honest with you, even with all the science, that's one of the best ways to start that I know of. I was asked to provide pretty much the comprehensive pathogenesis of fibromyalgia. It's tough going last, but when you're last, you're not taking up anybody's time, so we'll be done by 8, 9 o'clock tonight. Don't worry. So no, but this is the abridged version. But you know, I don't study chronic fatigue, but I find it fascinating. And I was fortunate enough to be asked to speak here 2 years ago, and I had a chance to listen to patients on a panel talk about what they felt like, and I got interested in it. I'm in no way an expert on it, but I find it fascinating. I certainly hope that more can be done to help patients with chronic fatigue. As I listened to the lectures this morning, and as I bring some new data of the last 2 years, I noticed that some of the themes are really starting to overlap. I'm not at all a fan that chronic fatigue and fibromyalgia are the same thing, and I'll try to make an argument for that. Counter to what you've heard about chronic fatigue, I stick my neck way out there. I think we know what fibromyalgia is, and I think we know what to do about it. And as we're finding out what it is and what to do about it, we're finding out that many people who have it have something else. And that may strike you as quite unsettling. And it usually does to the patients until I give them the evidence. So what I'll do best I can is I'll give you my view and how I put it together and how I help patients with it. I've taken care of patients with fibromyalgia for about 15 years, and I see 2 to 3 new patients every day. And I work 5 days a week. So that's a lot of people. And they get the credit for this, not me. They keep coming back and saying, what else do you have to make me sick? And you can't stop trying when people do that. So the credit goes to them. So let me tell you what they've taught me. Now first, I have a couple other disclosures just because we want to be upfront about everything. I've been advising Baron Gringelheim, and I actually have the chief scientific officer for 2 small companies that actually work on this problem. Since there isn't any money for us, we have to find our own money. The objectives here are to look at fibromyalgia from a comprehensive point of view and to begin to discuss a few things that haven't been brought up today and some that have. One is the issue of benign hypermobility syndrome. Autonomic dysregulation has been discussed, and I'll go over that. Sleep stage architecture, I'll add a few details on that. Dopamine, which I'm known for as a neurotransmitter. And this issue of cervical instability. So here's how we're going to do it. I'm trying to connect the dots. Patients are complicated, but I think the dots can come together. I'm going to try to link fibromyalgia with sleep stage architecture based on evidence, studies. Link the sleep stage architecture with restless leg syndrome and bruxism, grinding teeth. Talk about how restless leg syndrome is linked to autonomic dysregulation. How the autonomic dysregulation is linked to benign hypermobility, which runs in families and is certainly genetically associated. How autonomic dysregulation is controlled by dopamine in the limbic system. And don't worry, it's not as complicated as the last few slides. And finally, how does autonomic dysregulation have anything to do with cervical instability? And what exactly is cervical instability? Now, I don't need to go over what fibromyalgia is. I think everybody knows what that is. Chronic widespread pain. And we're a little fussy about it. We like people to really be tender. And there are patients who come in and they don't have tenderness everywhere, and we know it changes from day to day. And that's actually important to understand why it changes from day to day. But you pretty much have to have surface phenomena to have fibromyalgia. And it should be global. And it would be nice if the tenderness on the outside was as bad as the pain on the inside. And the story fits with the exam. And many times it doesn't. And I'll bring up why I think that's an important clue for clinicians. We've been looking at a lot of problems this way. This is from Stanley Block from Portland, Maine, 1993, Rheumatic Disease Clinics. You know, everybody's trying to help patients with fibromyalgia, at least if they're committed and and doctors that aren't too lazy. And so the ENT is looking at the TMJ, the sleep experts looking at the sleep, the cardiologist looking at the unexplained palpitations and chest pain. You get the idea. I'm going to try to make a case for the big picture. So we're going to start with sleep architecture. Above everything else, I believe that Harvey Moldavsky was right more than Harvey Moldavsky even thinks he was right. And Harvey Moldavsky is a sleep physiologist who just didn't buy it that people had pain because of a psychiatric cause. And he was a psychiatrist, he's still a psychiatrist, and he's quite famous. And I believe he did the first pivotal study. The problem was, it was in 1975, it was only 6 patients, and it was before the official criteria of fibromyalgia. But what he did was, he took 6 subjects, he put them in a sleep laboratory. These were college students. You know, he paid them, I don't know, $25 a night. And he hooked them to the EEG, and those of you who've had a sleep study know what this is all about. And you can go through the different sleep stages, the light stage 1 and 2 sleep on the EEG, the stage 3 and 4 deep sleep, kind of children get, and back up and down, and REM sleep. And you can see this while people are sleeping. And what he did is he disrupted stage 4 sleep. So they're sleeping, he gets a baseline, they go to school, they come back the next night, and pretty much without telling them much, as they're going into stage 3 and 4 deep sleep, he plays an auditory arousal, about 90 decibels, startles them into light sleep, but he's very clever. He doesn't play it long enough to wake them up. So they try to drift back into deep sleep naturally. He does it again. Does this all night long. Well, he did this for 3 nights, and the subjects basically developed non-restorative sleep, fatigue, a sense of stiffness and aching, and eventually they felt like a truck ran over their whole body and they were tender everywhere. Now that strikes me as important. Okay? And they stopped the study, and within 3 nights it all disappeared. So that's interesting. Certainly it sounds like an inducible process. We know we torture people by, well, I don't, but we torture people by sleep deprivation, right? All right? That's why some of the funding for fibromyalgia research is actually through the military and the CIA and so forth. They know what happens to people when you torture them by sleep deprivation. You can even make people psychotic. You can really mess up their brain. Moldavsky did the same study with REM sleep. He disrupted the REM sleep instead of the deep sleep, and it didn't cause any of these musculoskeletal or fatigue problems. He also did it in ROTC recruits, very fit young men and women, and it didn't do it either. But if you go to the VA, I teach at the VA, and you meet people who've been POWs and been tortured, they don't like to talk about it, but if you talk to them about it, they know what fibromyalgia feels like. And they describe something very reminiscent, and certainly they were in peak physical condition when they were abused like that. Unfortunately, Moldavsky, it didn't really take off. Everyone was still fixated on this psychiatric issue, and every time you gave anybody anything for stage 4 sleep, like amitriptyline, they would say, see, it's an antidepressant, it's a psychiatric problem, and so forth. But Carol Lentz at the University of Washington, of all places, in the nursing school, repeated Moldavsky's study in 1999, this time in 40-year-old women. And same thing happened. In the middle of this, though, in 1997, John Russell, who's very famous fibromyalgia researcher, tried to reproduce Moldavsky's study, but also look at neurotransmitter levels at the same time. And he found that he couldn't do it. But I got a chance to talk to John. And if you look at the papers, you'll see something very interesting. The arousal that fragments stage 4 sleep that Moldavsky used was a noise, a computer-generated startle. I mean, something really get you. Whereas Russell asked the patients, pick the music you might pick to wake up in the morning. Now, if they picked my kids' music, that would be a startle reflex for me. But it suggested that the nature of the arousal, particularly its startling ability to fragment and wake you, or at least irritate your sleep, may be as important as the lack of stage 4 sleep as well. So it looks like you can cause fibromyalgia by disturbing stage 4 sleep so far. Well, what about stage 4 sleep and restless leg? Well, this is a K-alpha wave complex. Slow wave sleep in a burst, and then rapid, and then back to quiescent again. You saw these already, the activity. And you saw them with restless leg. This is from Moldavsky's paper. This is what it looks like when you play that noise. It's also been described to me that if you're a normal individual and you're sleeping and someone drops a book, you'll get one of these on the EEG. It might not wake you up, but that's what they'll see in the sleep lab. Sounds a lot like me, like a startle reflex. And what is a startle reflex? An autonomic sympathetic burst. Okay? They're also seen with the restless leg, which restless leg and periodic limb movement are seen more commonly among patients with fibromyalgia. This is Muhammad Yunus, 1996, British Medical Journal. Fibromyalgia patients, this is RLS here, 31% in this group, 2% in controls, which I think we'd all agree that's a little low. But still, the point's there. And even 15% in RA. But you know what? 50% of people with rheumatoid arthritis have fibromyalgia too. So if we're going to talk about sleep and restless leg and K-alpha wave complexes and arousal, then in half the patients of RA, and then maybe you're going to see half as much RLS. So basically, looks like something's going on there that we can ask about. Then the question is, well, what is RLS? What is it? Well, no, if you ask the neurologist, say, we don't really know what it is. But if you ask Gilles Levine in Montreal, who studies this, and bruxism, grinding teeth, which people with fibromyalgia do all the time, breaking teeth left and right, it appears that it's an autonomic issue. Let's see. The other issue is, this kind of goes over some old information you got this morning. But the issue of fibromyalgia and its link to autonomic dysregulation. So you have this housekeeping function, your autonomic nervous system. You have the sensory, the motor, the autonomic. Everything you don't want to think about is controlled by your autonomic nervous system. Sleep, of course, arousal, running from the lion, epinephrine, adrenaline, metabolic rate, temperature regulation, sweat glands, heart rate, blood pressure, vagus nerve, bowel motility, GI, acid production, bladder function. Sound familiar? A lot of these things in the fibromyalgia brochure, they have nothing to do with Moldavsky's first study with sleep, but it has everything to do with autonomic. These are just a few references in case people wanted to look some things up. But I won't go over it again. But in one of them, simply use tilt table testing. Picture Frankenstein, the tilt table testing to see if patients can maintain their blood pressure. One of the fundamental issues of the autonomic nervous system is to vasoconstrict as you stand. I've always thought that maybe we should do fibromyalgia studies in giraffes because they'd have the toughest time maintaining their blood pressure. You have to think about that one for a second. So other issues with dysautonomia is that 24-hour heart rate variability is a very important thing for you to know about. There are 9,300 references on Medline for this. This is a well-documented tool to measure sympathetic and parasympathetic function in the brainstem as it affects respiratory rate. So as we inspire, our filling pressure changes and the variability is there. This will change based on whether you lean more parasympathetic or more sympathetic. And the sympathetic nervous system is a pacemaker in the brainstem, okay? And how much your pacemaker is on or off genetically is no different than whether you're a faster runner, slower runner, taller, shorter. See? This varies among the population. That's an important point. But look, you'll see more and more in the future use of heart rate variability to actually measure sympathetic and parasympathetic activity. It sounds like in chronic fatigue research and also in fibromyalgia, of course. So Gilles Levine would say in Montreal that restless leg syndrome and bruxism are dysautonomic, that these are just expressions of autonomic arousal. You can probably imagine a few others. Child gets up in the middle of the night, thinks somebody's in the closet, won't sleep. What do? Give them a drug? No. Calm them down. Try to turn off that sympathetic fight or flight response, right? Bruxism and restless leg syndrome are things you can ask of your patients. Why do not all patients have this if this is such a fundamental issue? I don't know. But it is helpful to at least ask. And then it appears that the K-alpha wave complex is probably an expression of an autonomic burst. That's probably why everybody has these. It just depends how many you have, when they come. If they fragment your stage 4 sleep, you're in trouble. So the next link is, okay, so we've got Moldavsky causes this by a lack of stage 4 sleep. The mechanism is to disrupt stage 4 sleep with this noise, which sounds like turning on a startle reflex, and it also appears that these reflexes, expresses, restless leg, and bruxism are common among patients with fibromyalgia already. What's going on with hypermobility? Well, hypermobility has criteria, and one of the authors is Dr. Rodney Graham. I had a chance to meet him. He's in London. He's an older fellow. And he has done some interesting work looking at these individuals, trying to figure out why they have such unusual things to say sometimes. Now, hypermobile people, we're not talking about the Cirque du Soleil people or the Chinese acrobats. We're not talking about that. We're talking about benign hypermobility. I'd venture to say that a very large percentage have it in this room. It's very common. It's like blue eyes. It's a trait. It's not a disease. But they tend to get flat feet, chondromalacia patelli, so kneecap pain going up and down stairs, unusual spine injuries. They're a little more flexible. Certain occupations pay the bills with people with hypermobility, podiatrists, chiropractors, very common, helping people who have this trait because they can get into trouble and need some help. We see them as well in the medical community, but sometimes we don't recognize them because we're not looking for this. Basically, people with hypermobility, 25% of the U.S. population, have evidence of sympathetic overactivity naturally. Not to a pathologic level, but that pacemaker seems to be on a little bit more. This is not fibromyalgia, this is hypermobility. So what Roddy did is he took 48 patients with joint hypermobility, 20 controls, this is a controlled study, looking for sympathetic linked questions like syncope, pre-syncope, passing out, palpitations, unexplained chest pain. Guess who gets that? People who are flexible. Fatigue, heat intolerance, temperature dysregulation, that type of thing. He also took 27 patients and 21 controls, and they did autonomic testing. They did cardiovascular, vagal, and sympathetic function, orthostatic testing, and basically what they found is that orthostatic hypotension, postural orthostatic tachycardia syndrome, POTS, and other forms of orthostatic intolerance were seen in 78% of patients with joint hypermobility and 10% of controls. Now, these people aren't going to the doctor saying, I'm falling down every day. What he's showing is that they're different, that they lean towards autonomic dysregulation. And that's really the important point here. If they lean towards autonomic dysregulation and increased sympathetic tone, I find that useful to know who can touch their toes and who can't. And I usually look at wrist extension and cervical rotation because by the time you get to me, you're pretty stiff and you're not very comfortable. But you can look for pes planus, and you can ask for things. Were you in gymnastics, dance when you were a kid? Do you have flexible children? There's things you can ask just to kind of get a feel for this. And if you know that they have that trait, which runs through all their family, then you have to watch out that maybe you're dealing with somebody who has the potential to increase their sympathetic tone a little bit quicker and faster than somebody else. You can also do a little experiment. And I tell the patients this. Look at a group of people you know. You know well. Look for that person who goes the extra mile, tries the hardest, most dependable, reliable, empathetic, thoughtful, multitasking, go, helps others before themselves. They all touch their toes unless they have a bad back. Look at your staff when you get back to work, okay? This trait is overrepresented in some occupations. I'm convinced that most doctors have it, although for some reason it doesn't look like they do. Certainly nurses do. I take care of more teachers than principals you can imagine. Engineers have it. Artists have it. Certainly high-level Olympic athletes all have it. We joke that you can't even get an interview at Microsoft unless you can touch your toes because they want that fast, rapid brain. And people in the Mensa Society also bend all over. So again, this is a lot of people. These are the doers, the multitaskers. Okay? So basically, with that background, this is how I think of it. So here's my model. So you've got hypermobile patients all over the place there. I got to watch out for them because we already know that they can get chondromalacia patelli, pes planus, they get plantar fasciitis, unexplained chest pains. There's a lot of argument with mitral valve prolapse, and I don't want to go into that, but it's possible. So they're out there. And I'm worried that Rodney Graham's right. These folks tend to develop autonomic dysregulation quicker than other people. Okay, most of them are very functional and doing fine, but they can have this stress response go to rev up a bit. That autonomic dysregulation can affect the GI tract, GERD, and irritable bowel syndrome. It can affect vasomotor instability, and Raynaud's phenomenon, sweat glands. I shake someone's hand, and I know what we're going to talk about. People have clammy hands because they're kind of worried they're going to see a doctor and not sure what I'm going to say. But a lot of these folks have been to lots of doctors, and I'm not really scaring them. And I know we're going to be talking about autonomic issues, and then we'll try to figure out why and what we're really going to talk about. The other thing that's really not talked about much, but I'm interested in, is how does the autonomic nervous system affect expression of behavior, panic disorder? Well, it is a fight or flight response. It's a regulatory function. The reason you have a panic attack in the middle of Safeway is because the regulatory mechanisms that control it are not controlling it very tightly, and it turns on by accident at the wrong time. Does it have an effect in post-traumatic stress disorder? Well, I would think so. How about palpitations, unexplained chest pains? ADHD, there's a lot of discussion about autonomic issues in ADD and panic disorder. And then I think we can probably agree that it can inhibit restorative sleep. And if it does, I think Moldavsky is showing what you get. So this is the way I look at the world. I don't try to make people sleep. I try to let them sleep. I try to turn off the arousal that fragments their sleep. And the arousal appears to be autonomic. Where all the new stuff is what turns on the autonomic nervous system. Which leads me to what controls the autonomic nervous system. And that's this issue with the limbic system. This is from Patrick Wood. Patrick Wood is a very fine author, young up-and-coming researcher from LSU, who's done some remarkable work on explaining to the rest of the world how dopamine works in the limbic system in the central brain. And basically, I'm interested in this spot right here because Patrick told me to be interested in this spot. This is the hippocampus. And the hippocampus has a job. And then here's the thalamus as well. Thalamus affects some of the pain perception issues that I'm not going to go into with fibromyalgia. The hippocampus works this way. Lion jumps out from the tree. What happens? You see it. You're scared to death. Your brainstem fires. Heart rate goes up. Blood pressure goes up. You run like crazy. Hopefully you're a survivor. Okay? You get away. Why does your heart rate come down from 200 eventually? Because of your hippocampus. Your hippocampus is in charge of inhibition of the brainstem stimulation adrenaline response. Okay? If the hippocampus isn't working, you're in trouble. So let's say the next day, another lion shows up. You've seen a lion. You have memory. You have experience. The brain adapts. The brainstem turns on quicker. The hippocampus turns off quicker. You run quicker. Somebody else gets eaten. Again, now you're more likely to be a survivor. What happens when the 10th lion's there? Well, pretty much the hippocampus is off. And you're ready for a lion at every moment. You think there's lions everywhere. But you are going to survive probably. The problem is we have many people live in abusive situations where they sleep in the cage with the lion. And what Patrick tells me is that the hippocampus is not functioning in fibromyalgia. Based on MRI, it's atrophied. Based on functional MRI, it's not working. And based on PET scan data, which he just did, it doesn't make any dopamine. And the hippocampus runs on dopamine. Dopamine has been very important in Parkinson's research, but this is another area. And people with fibromyalgia don't necessarily get Parkinson's, although Parkinson's patients can get fibromyalgia. Again, all you have to do is not sleep normally. But what this is it takes the discussion to another level. All these areas here in the limbic system, these are areas that are dopamine deficient compared to normal controls. This is a controlled trial, so this is very important. This was published about 5 months ago. What I was involved with, not knowing about Patrick's work, is that we were looking at restless leg syndrome as an inhibitor of normal sleep and trying to find a way to block it so that maybe you'd sleep a little better. And this is what it led to. Pramipexole is same as Mirapex. And again, none of this is FDA approved, so just don't do anything I tell you. But at least I'll share with you. I just present evidence. So pramipexole is now FDA approved for the treatment of restless leg, but for the last 10 years it's been available, and every doctor who in the sleep labs used it. So we used low doses, and we found that it started to make a difference in the restless leg. Somebody in Tacoma, of all places, just south of me, looked at health assessment questionnaires in RLS patients and found that fatigue, quality of life, musculoskeletal stamina, all got better with treating restless leg. That was interesting. I think he's measuring early fibromyalgia, by the way. And so we started developing this medication. It's interesting. Pramipexole stimulates the dopamine 3 receptor. So now we're going from dopamine down to the dopamine 3 receptor, not dopamine 1, 4, 5, 6, actually there's 6 to 7 now. Has a little effect on the 2 receptor. We're actually talking about specific receptors for the neurotransmitter, and guess where they are? They're not everywhere. They're hardly anywhere. They're in the hippocampus. Yeah, that's what it is. Now, I didn't know that until I found out. So I'm going to review the study that you have in your handout. It's very important, if you're interested in this topic, to read the whole paper, especially the method section, please, because there's some important issues here. Basically, this was we did 2 preliminary studies, then we did, honest to goodness, randomized placebo-controlled trial. And the way it was designed is this. This was an escalating dose of pramipexole up to 4.5 milligrams at bedtime. The dose for restless leg is 0.5 to 1, okay, down here. But we had already tested up to 10 milligrams. Again, I'm not suggesting you do that. I'm just saying we did. And then there was a placebo group here, and we followed them for 14 weeks, 8 visits. Okay? We used proton pump inhibitors to block nausea. We found that before we could help anyone with fibromyalgia with pain or fatigue, we could at least help them with their nausea. So we incorporated that into this. One important thing, this is the only fibromyalgia study you will see where the placebo was calcium carbonate. Most placebos are lactose, which strikes me as a very odd thing to do in a fibromyalgia study because of the GI issues. So people who had any kind of GI side effect, they had it on the placebo even though it was Tums. The other issue is this is the only fibromyalgia study that allowed patients to take other drugs. The reason it's so hard to get these studies done is people have to stop all their medications. So who are you going to get in the studies? The people who have the mildest disease who are willing to stop their drugs. 50% of people in this study were on chronic narcotics. 30% were disabled. These are people who would never be allowed into the Lyrica studies, the duloxetine studies, much less would ever go in it. You had to have fibromyalgia for at least 6 months. You had to have pain at least 5 out of 10 on a visual analog score, so I mean, fair amount. And this, very important, you could not be in the study if you had cervical pain with extension. It's really important. Or if you had an Epworth score rather than 12, which is a screening test for sleep apnea. Okay? We didn't have enough money to do sleep apnea screening, but I wish we did, but there it is. Basically what happened, red is the drug. This is the visual pain score. They started off about 7, 8. Improved, statistically significant by the higher doses. This is the placebo through here. This was the primary outcome. It looks modest because I think I'm the only person who puts the whole scale on here. If you put just this and this, it looks really big. But I didn't want to do that because I didn't want to hype it. But there it is. It helped a lot of people. In fact, I'll compare it with some other drugs in a moment. This is comparing pain relief scale where patients were asked at the end of the study, did you have no pain relief, a little, moderate, a lot, or complete? Now the red is the active and the dark is the placebo. So you see there's some placebo people got better and there's some people on active didn't get better, but it tends to skew towards a response. This is the famous Fibromyalgia Impact Questionnaire, which also measures psychiatric benefits and all kinds of things that a dopamine 3 receptor agonist for Parkinson's and restless leg isn't likely to do much for. But even with this, the active group was statistically improved. Just to be thorough, there were some things that didn't seem to change much compared to the placebo group. You'll notice here the tender point score went down 50% in the active drug, but went down 35% in the placebo group. So you get what you get. The global score was significantly better in the active group. So was the fatigue score, function score. HAM-D is the Hamilton Depression score. It wasn't much. It looks like a difference, but it wasn't statistically significant. Neither was the Beck anxiety. So depression, anxiety didn't seem to make a big difference. But if you look at other studies like duloxetine, amitriptyline, milnacipran, all these other things, they treat depression. So you're going to see some benefits there as well that might be helpful for patients. I'm going to go over this more tomorrow, but this is in your other handout. There's another paper, a review on all the different drugs you can use, and even some you can't, for fibromyalgia. And there's one study that's not in there that just came out last week. But it basically, if you want to compare drugs, do it this way. Subjects with greater than 50% reduction of pain. So that threshold. When you do a study for osteoarthritis, they're looking at 25-30% decreased pain, by the way. But we're looking at 50% decreased pain. And you want to compare the active arm, how many people taking the drug were able to get at least 50% decreased pain, versus how many people in the placebo, because there's always going to be some placebo responders. And what you'll see is pregabalin, this is the Lyrica, 29% had that 50% decreased pain, 11% of the placebo. This is the milnacipran study. You can't get that yet, but they're doing a lot of work on fibromyalgia. This is the duloxetine, which is Lyrica. This one, they had men in, which showed some didn't quite meet statistical significance. This one, they kicked out all the men, which that's discussed in the paper, and I'll leave that for you guys to read. And they did much better. This is sodium oxybate, which is called Xyrem, which is used for narcolepsy. Ongoing phase 3 trials there. This is not 50% decrease, it's 20%, but I wanted to put it in just for completeness. This is ropinirole, which is the other dopamine agonist. 45% achieved this decrease 50%, but the placebo responders did really well. And so it wasn't statistically significant. And then this is the pramipexole one. This spreads pretty good. So, and then this is the reference. You have that. So I think you'll find it interesting. The authors gave me a lot of leeway to sort of give my opinion. So and I don't work for any pharmaceutical company, so I gave it. So the last one is probably the most important issue, and it finishes up. You notice in the pramipexole study, I said you couldn't be in the study if you had pain with cervical extension. Have you ever seen that in any study for fibromyalgia? I'll answer for you. No. Nobody ever thought of it. Nobody ever did it. Here's why. I was at the National Fibromyalgia Research Association meeting in 2002. It was like a think tank. Doctors talking to doctors. And only doctors with crazy ideas were allowed to come. And it was before there was any evidence on dopamine agonists at all. Patrick Wood got to go the next time, but I got to go this time. So, and I don't throw stones because I live in a glass house. I mean, there were some really odd ideas there, but so I'm listening to these two guys, Michael Rosner and Dan Hafez. They're talking about how people with fibromyalgia and chronic pain have often cervical problem that needs surgery. And they're talking about the Chiari discussion, where people compress their cord with the cerebellum that squeezes down through the foramen magnum. And I hadn't seen that much, but they were talking about it. But they showed me this MRI where they looked at the neck in different positions. Now, chiropractors are way ahead of us. They look at position. They're interested in movement. We just get an MRI and ask you to hold still, right? But if you look at the MRI in different positions, you see that this dynamic structure, the neck, moves. And when things move, they change shape. And he was making the point that the MRI may look pretty good in neutral, but may look pretty bad in another position, and that we're missing something important here. I thought that was interesting. I knew that people with fibromyalgia had had a previous trauma many times. I thought maybe a few people might benefit from expanding the MRI and looking a little differently at it. So I'm waiting my turn. The next guy to talk is this fellow here, Dr. Krasikov. He doesn't take care of people, he takes care of rats. And what he does is he studies the rat's spinal cord. And what he shows is that if you have a lesion in the spinal cord at a certain dermatome, and you sleep deprive the rat, the pain is really broad and more intense. Okay? If you don't sleep deprive them, it makes sense. It's like the textbook. It's not amplified. But the other point he made, though, is in an anesthetized rat, if you touch the cervical cord, you don't hurt it, you don't crush it, you don't injure it, you just touch it. Just bump it. It activates the sympathetic nervous system, it affects heart rate and blood pressure. Well, that was a big thing to me because I'm the next guy talking about how the sympathetic nervous system may be fragmenting sleep and causing fibromyalgia. And I'm thinking, how many people are hitting their spinal cord and bumping it pretty much, not damaging it, just bumping it. We don't know. And if this rat data is true, then maybe it's a mechanism by which you can activate the sympathetic nervous system and then fragment the sleep and cause fibromyalgia. Again, one more domino to knock them all over. And sure enough, that's probably what's going on, at least as best I can see. So this is a neutral MRI, and I don't know how many people here read MRIs? Anybody? There's a few. Okay, let me walk you through it. It's not so bad. So they're obviously looking that way. These are the discs, or these are the vertebral bodies like here, and unfortunately it's not too bright from my direction. These are discs here, look like little pillows. This is the spinal cord in dark, and fluid shows up as white here. Also fat shows up as white, but this is fluid. Normal disc, you can see that the space here is such that, oh, does that help maybe? So what you can see is the space here that protects the cord. The cord's designed to float and suspended within this tube, just like the brain is designed to float. It's not designed to bang into the side of your skull. Let's call it a concussion. And so as you move your neck forward, in a normal person, the canal opens just a little, and as you extend, it tends to narrow. But you're designed, no matter which way you bend, you never bump into the cord. Okay? As we get older or injured, you may find that a disc bulges out to here. It's this black here. There's more black out here than there is here. And you'll see that this takes up some space. And there's less fluid, but there's still fluid. Here's a bulging disc here. This would be considered very mild. So this person had horrible pain. And if we had done a regular MRI, this is what we get. And we'd say, don't worry, a couple of minimal bulging discs, don't worry about it. Well, this is what happens when you look in a flexion view. Okay, now nobody does this. There's 5 centers in the United States that do this, now 2 in Europe, which I'll tell you about later. So you bend forward, and you can see there's plenty of fluid around the cord. It doesn't look like it's in distress in any way. Here's the extension view. There's no fluid here. This disc bulges much more, and more importantly, this here, that's the ligamentum flavum, so is this here. And it's buckling. Okay, it's buckling and pushing in. Unfortunately, it's pushing in on the spinal cord. So if this were a rat, their heart rate and blood pressure go up, but this is a person. So this appears to be evidence of intermittent spinal cord abutment. Now, we can't get in there and look at the cord. There's no cord signal. There's no injury to the cord. Most of the time, the cord's fine, just when you look up. This is what we get from our radiologists, and it's very helpful to go over this with the patient. So we get the views you just saw, and then we get the views with the numbers, which I'll show you right now. So here's that same regular neutral view. And what Hafez tells me is I want to see at least 1 centimeter of diameter. He's quite strict on this. And he believes that most people are about 1.2, 1.3, 1.4. So 1.4, nice. Well, little bulge, we're down to 1.03. 0.94, he would not like that, but I got to admit, I see fluid. I mean, I got to say what I see. Inflection, see how large the numbers get? They get bigger. And also the cord is tethered so it stretches, kind of like Gumby. I mean, it does actually, the caliber shrinks down. That has been studied, by the way. But they've never looked at the canal. So you'll see that the cord is in fine shape here. And then here, you'll see that my radiologist got this down to 0.74. We've seen people as far down as 0.45 walking around. Been everywhere, neurologists, seen everybody, nobody knows what's wrong with it. Now, if you take this and you send it to the neurosurgeon, they're going to say, okay, I believe. But if they don't have this, they can check nerve tests, nerve conduction studies. It doesn't show a thing. Okay? It's not injured. It's irritated. And it's the irritation that activates the sympathetic nervous system. So there's that view again. Okay? Doesn't look good to me. So basically, I'll go over the data, what we've done, just to finish up, is we've done a pilot study to say, okay, can we get the news out there so people can go out there and study this? So we looked at 2 random months, and we said, who comes to see me? Okay? I don't see people for neck pain. I see people for unexplained pain, rheumatoid arthritis, and so forth. And we said, how many of these people have evidence of cord compression, abutment, flattening, and at least narrowing to 10 millimeters? If they don't get to 10 millimeters, you got to at least be narrow. And we said, how many people had this? Basically, what we saw in 2 months is we saw 32 people had a connective tissue disease, rheumatoid arthritis, and so forth. 53 had fibromyalgia. No surprise, I studied that. And 22 had, we don't know what they got. They hurt all over. They sound like fibromyalgia, but they don't have enough tender points. The Europeans might call them chronic widespread pain. And these are the ages here. You've got them in the handout. What these are questions that we ask people. What does it feel like to sit in a dentist chair? What does it feel like to have your hair washed in a hairdresser sink? What does it feel like to look up at the stars? Actually, that's a new one. We didn't use that one. We used a grip strength. Is it weak? Romberg, feet together, eyes closed. People go, ooh. Okay, that's not normal. Okay, and so we look for those clues. If you had those, I got an MRI. If you didn't have those clues, I save you an MRI and work on your rheumatoid arthritis. And so what we found was that, let me show you. What we found is, like, for instance, unsteady gait, not big difference between the three groups. But look at this, Romberg, 9% in the people with connective tissue, 70% of the fibromyalgia patients that saw me those 2 months, nearly 70% of the unexplained pain. Now, this is not a Romberg where you fall down. This is a Romberg where you are unsteady. Okay, so, and it's a Romberg for at least 8 seconds. So with your eyes closed for 8 seconds, it's not your typical Romberg. So, but sync pain, hardly anybody had sync pain except for the fibromyalgia patients, 68%, and the unexplained pain, 59%. These people will tell you they have this if you ask them. And if they have it, you want to go find out why. So basically, this is the take-home point. Only one of the connective tissue people even got an MRI. Okay, we have no controlled data here. We have nobody who is normal. We need that study. But this is a preliminary pilot study. Of the fibromyalgia patients, I got 49 MRIs, 92%. I got 91% of the pain people just because of the way they answered their questions. And by the definition of abnormal, 66% of the FM patients had abutment, compression, or flattening of their cord and narrowing below 10 millimeters at least one space. And 77% of the unexplained pain patients. But here's the real point. The new view was required to show this in 71%. Only 29% of the patients who had a spinal cord problem showed up on the regular MRI. You're not even going to see it unless you look in extension. And so that's why nobody's ever seen it. You might also ask about the Chiari. We found 2. Found some places with flat cord. 8 people with flat cord didn't have compression on the neutral view. But their cord's flat. It was on extension, but it was on neutral. Radiologists didn't know what to say about that. I said, well, how does it get flat? It's got to be squeezed. You're not born with a flat cord. And they said, well, we don't see it. Well, they see it when you extend. And then we found one case of multiple sclerosis and one of multiple myeloma. That was a little scary. We also looked at these questions, how well do they predict who needs an MRI? We don't want to get an MRI in everybody. We found that the psych score, they tend to have a better psych score, and they tended to have higher age. But that's it. Nothing else was statistically significant. And this is really meaningless anyway because there's no controlled group. There's no normal group. No one knows if normal asymptomatic people ever bump into their spinal cord. The rat data would argue against it. This data would tend to argue against it. You could think of the adjacent disc as a control disc because it's not being bumped, and the people who've had surgery who fix the abnormal discs usually do very well, so there's plenty of circumstantial evidence, but we don't have a controlled trial. The good news is they're doing one in London right now, and I'm a co-investigator on a Barcelona study that's just about to get started. The US study, we're trying to collect money to get it done, but so there may be 3 studies that actually answer the question, is this abnormal pathology or just something show and tell we found in fibromyalgia patients? I think it really matters because there's a reason why it's an exclusion criteria in the Pram-Pexel study. It's an autonomic arousal. So is sleep apnea. If you read that paper, don't give people dopamine agonists if they have untreated sleep apnea or cord compression. It doesn't matter what you do to turn off the sympathetic nervous system, the limbic system, if the cord is turning it back on at the brainstem or if you need your brainstem to breathe. You just can't treat fibromyalgia that way. You can use an antidepressant, you can use an anti-epileptic, you can use analgesics, but you can't fix the dopamine axis that way. So basically, I kind of went over these already. What are we going to do? What needs to be done? And we don't need to know if normals control or compress their cord. These are just questions for the future. So basically, to take you back to what I see, I know everybody in my office who has hypermobility or not. RA patients, lupus patients, fibromyalgia patients, everybody. Because I'm watching out for their autonomic nervous system. I'm watching out for this. And I'm trying to fix this. But now what we know, just to add, is cervical cord compression increases autonomic dysregulation, the rat model. Hypermobile patients can bend farther, more likely to bump into the cord. They already have higher risk for ligamentous injuries of the spine after motor vehicle accident anyway. And untreated sleep apnea also increases autonomic dysregulation. And dopamine agonists decrease autonomic dysregulation. So, so far, that's my picture. So I want to thank you all for your attention. Hope it wasn't too much too fast. I think there's a panel, so there's probably time for questions later. Thank you very much.